Hi, my name is Raghu Sithala. I'm an instructor of medicine and emergency medicine at Brigham and Women's Hospital and Harvard Medical School. I'm a practicing intensivist as well as an emergency physician. I have no disclosures or conflicts of interest to report. Today we'll be talking about ultrasonography in the intensive care unit. Our goals for today are to discuss the utility and various applications of bedside ultrasound in the intensive care unit, provide a brief overview regarding the types of ultrasound intensivists should be familiar with, including cardiac, thoracic, abdominal, vascular, and ultrasound for procedures. Ultrasound has become increasingly used in the intensive care unit over the past decade. This has been a huge paradigm shift, traditionally with ultrasound being used by radiologists and cardiologists solely. But over the past decades, lots of experience outside of these diagnostic arenas has really moved ultrasound to the forefront for intensive care unit medicine as well as emergency medicine and other acute care providers like surgeons and anesthesiologists. Ultrasound can be considered now an extension of the physical exam for critical care providers. Although there is no formal certification at this time for ultrasound training in the intensive care unit, there have been guidelines published by organizations such as Society of Critical Care Medicine. Additionally, the ACGME now actually requires ultrasound training for all of the critical care fellowship pathways. Anesthesiology, internal medicine, pulmonary, and surgical critical care have specific ultrasound requirements they should meet in order to graduate their fellowships. Why use ultrasound in the intensive care unit? There are many benefits. It can be obtained real time. The treating physician is the one performing and interpreting the scan. Therefore, they can incorporate other clinical data to understand the clinical scenario better. And it can be repeated as often as need to monitor treatment effects. Now, ultrasound being performed by the intensivist is done for a different purpose than comprehensive and formal ultrasounds being done by radiologists and cardiologists. It is usually done to answer a specific question, such as, why is my patient hypotensive? Is my patient likely to benefit from a volume bolus? Sometimes it's used for diagnostic purposes as well, for critically ill patients that can't travel. For example, you have a patient that you suspect a tension pneumothorax. A quick bedside ultrasound can confirm this diagnosis with relative accuracy. Another scenario could be a patient in which you suspect a massive pulmonary embolism and they're too sick to go to the CT scanner, or they have an elevated creatinine, they can't get a CT scan. A quick ultrasound performed by the intensivist can assess for right heart strain as well as identify a DVT. There are some pitfalls to ultrasound, and these should be well known before utilizing this tool. The first is, especially in the intensive care unit, we may not always get adequate views. There are lines, tubes, patients have surgeries, patients have huge ventilatory requirements where they're unable to be moved because they're so unstable. So that's the pitfall number one. The second pitfall is that ultrasound can be very operator dependent. A skilled practitioner will have much more success in obtaining images and interpreting them over a novice. And lastly, physicians could make incorrect interpretations of ultrasound. And this will only get better with practice. Two questions may arise for the novice ultrasonographer in the intensive care unit. Can intensivists competently perform bedside ultrasound? And is it really helpful in the management of ICU patients? A brief review of the literature will give us a resounding yes to both of these questions. Now, this is one of the earlier studies that looked at whether intensivists with a brief training period were able to identify left ventricular function abnormalities and normal LV function. And this study demonstrated that with just a brief training period, intensivists were able to identify normal LV function in over 90% of the cases and abnormal LV function in about 80% of the cases. The kappa statistic for the agreement between the intensivist and the echocardiographer was good at 0.72. In this study, intensivists were able to have a diagnostic accuracy of 95% for diagnosis of DVT, with a sensitivity of 86% and specificity of 96%. In this meta-analysis, we see that pleural ultrasonography obtained by mostly non-radiologists had a specificity of 98% for diagnosing pneumothorax and a sensitivity of 78.6%. This sensitivity was well beyond the sensitivity of chest radiography. And Daniel Lichtenstein, who can be considered the father of lung ultrasonography, demonstrated that using his blue protocol, he would have been able to diagnose correctly in over 90% of the cases compared to conventional methods of X-rays and CAT scans and et cetera. In this study of intensive care unit in Italy, they demonstrated that with a ICU ultrasound protocol, as soon as the patient was admitted to the ICU, they were able to confirm the diagnosis in 58% of the patients, modify the admitting diagnosis in 25% of the patients, and they were able to, based on their ultrasound, prompt further testing in 18% of the patients. And their ultrasound findings led to changes in medical therapy in about 18% of the patients and led to early invasive procedures in about 21% of the patients. In this study, intensivists were successful in obtaining a diagnostic limited transthoracic echo in about 94% of the patients, and they interpreted their studies correctly in 84% of the patients. The limited TTE performed by the intensivist provided valuable information in about 37% of the patients that led to important changes in management. And in about half the patients, it added new information that did not alter immediate management. So as we can see, the literature supports the use of bedside ultrasonography in the intensive care unit. Now, what are we actually talking about when we are talking about critical care ultrasound? There are 5 major areas that every intensivist should be familiar with regarding ultrasound use in the intensive care unit: cardiac, thoracic, vascular, abdominal, and for procedures. We will now move forward and briefly overview each of these ultrasound applications. Now, there may be advanced applications that intensivists are doing, but this is the basis and core ultrasound that all intensivists should be familiar with. So critical care echocardiography really is meant to answer a few of the following questions. What is the life-threatening etiology of my patient's shock? Is my patient likely to be volume responsive? Does my patient have a severely abnormal LV function? Does my patient have signs of acute right ventricular failure? And is there obstructive shock playing a role in my patient's condition, such as pericardial tamponade? And then lastly, are there gross valvular abnormalities? So this is the first view that we will obtain in the 5 views that we are needing for critical care echocardiography. The parasternal long axis. We used a phased array probe, commonly known as the cardiac probe, and the probe marker will be pointing towards the patient's right shoulder in alliance with the cardiology convention. Now we can see the following structures. The most superficial structure or closest to the probe is the right ventricle. Immediately below that, we see the left ventricle. And then on the other side, we see the aortic outflow tract. Below the aortic outflow tract, we see the left atrium. And below the left atrium, we can see the descending aorta. We can also see the pericardium, for which the 3 red arrows are pointing at. And we can see the valves, aortic valve, as well as the mitral valve. Now this is a great view of getting general LV function and approximate size of chambers. We can also identify if there is a circumferential pericardial effusion in this view. Now we can see here, this is a normal left ventricular function. The things that we need to identify for left ventricular function are the endocardial borders, as we can see here, and their excursion with systole. The LV cavity should get smaller with systole. And also, the myocardium, which is here and here, needs to thicken with systole. The easiest way to approximate LV function is just by gross visualization. There are many complex equations and measurements that you can do, but really, gross visual estimate will be enough for the intensivist. The next view we can obtain is the parasternal short axis. With the prior view, you will rotate the probe 90 degrees clockwise, and now the probe marker will be pointing towards the patient's left shoulder. And we can see here that in this view, the left ventricle will be cut into a circle cross-sectionally. And the best area that we want to cut across is at the level of the papillary muscles, visualized here. The LV is a circular structure in normal left ventricles. We can see here the right ventricle hugs the LV almost like a crescent, interventricular septum, and here are the papillary muscles. And we can see that the LV is much larger than the RV. This is a great view to obtain an estimate of the gross ventricular function. Now we can see here the LV cavity becomes smaller with systole, and the myocardium thickens, and there is significant movement of the endocardial borders, indicating that this patient has a normal left ventricular function. Additionally, we can see signs or secondary signs of right ventricular failure, and that would be this septum here, which is part of this circle, becomes flat, and we see what is called a D-shaped ventricle or septal bowing. The next view we can obtain is the apical 4-chamber view. We will slide the cardiac probe to the point of maximal impulse, and have the probe marker pointing to the left side of the patient. In this view, we get a long axis view of the heart and are able to visualize all 4 chambers. Here we have the left ventricle. Here's the mitral valve. Here's the left atrium. And here we have the right atrium, tricuspid valve, right ventricle, interventricular septum. And notice that the apex of the heart here is made up mostly of the left ventricle, which is the case in normal hearts. Now, this is an excellent view to see gross left ventricular function, gross valvular abnormalities such as mitral regurgitation or tricuspid regurgitation. We can get a view of the pericardium and see if there is a circumferential pericardial effusion. But the biggest benefit of this view in the acutely decompensating patient in shock is to see the RV size relative to the LV size. Now, in this normal heart, we can see that the RV is smaller than the LV. The RV is typically about 2/3 the size of the LV. In signs of acute right ventricular dysfunction, such as pulmonary hypertension or acute PE, you will see the RV become larger than the left ventricle and start to take over and make up the predominant composition of this apex here. So in this clip, we see a normal sized right ventricle with normal cardiac function. The next view is a subcostal long axis view. This is a great view to obtain in acutely ill patients, such as during a cardiac arrest or during a trauma resuscitation. This view is obtained in the subxiphoid region, away from the chest. So active procedures such as chest tubes, thoracotomies, CPR can be ongoing, and you can still obtain this view. In this view, you get a gross visualization of all 4 chambers. We have the left ventricle, right atrium, left atrium. You can see the valves, mitral valve, tricuspid valve. You additionally get a circumferential look at the pericardium, as we can see this bright hyperechoic structure surrounding the heart. This is an excellent view to assess for pericardial effusion or tamponade. It also is a good view to assess for gross ventricular function. And we can see that this view is really obtained through cutting through the abdomen. Here we can see the liver, which is a great sonographic window to use to obtain this view. And here we see a normal left ventricle and right ventricle without any pericardial effusion and good cardiac function. The last of the 5 views that we will need to obtain for basic critical care echocardiography is the inferior vena cava. This view will be obtained with the probe marker pointing up and down. So from the last view, the subcostal view, where the probe marker was pointing to the patient's left, we rotate 90 degrees counterclockwise, having the probe be vertical, and cut through the inferior vena cava longitudinally. Now here we see the inferior vena cava as it enters the right atrium. And here is the liver. Now the point where we want to make our hemodynamic assessment of whether the patient is fluid responsive is distal to the entrance of the right atrium, typically distal to where the hepatic vein visualized right here takes off. So the red arrow is pointing to the specific point where we should be making our hemodynamic assessment of inferior vena cava variability. So let's take a minute to discuss this concept of inferior vena cava evaluation for fluid responsiveness. This is based on the changes in the inferior vena cava with respiration. Now, it's been best studied in mechanically ventilated, fully sedated patients without any spontaneous respirations. Now, in these patients undergoing positive pressure ventilation, with positive pressure ventilation, the IVC will actually distend. And having a respiratory variation greater than 12 to 18% with positive pressure ventilation predicts volume responsiveness, which means that a fluid bolus would increase the cardiac output in these patients. Now, this concept of IVC variability has been less studied in spontaneously breathing patients. There is not a great literature base for using this, but it is still used by most intensivists and emergency physicians. There is decent literature to support that in spontaneously breathing patients, IVC variability predicts a good estimate of CVP. Now remember, in spontaneously breathing patients, this is negative pressure ventilation, which means that with inspiration, the IVC actually collapses, which is the opposite of positive pressure ventilation, where with each breath, the IVC distends. So the greatest agreement in whether a patient is going to be fluid responsive for the spontaneously breathing patient is if the IVC is small, typically less than 2 centimeters, and if with respiration there is greater than a 50% collapse. This suggests fluid responsiveness in the spontaneously breathing patient. So here we have a case of IVC variability with respiration. The IVC is small, and we'll play the clip again. We're going to look at this point right here where the hepatic vein takes off, and we see that there's greater than 50% collapse of the inferior vena cava. Now, sometimes it's easy to visualize this in something called M mode. This is M mode. M mode is essentially a graph of time on the x-axis, with the vertical axis being the ultrasound findings on just this one line here, this white line up here. So to reiterate, in M mode, we have time on the x-axis, and the vertical axis is the ultrasound findings that are on the white line right here. So we can adjust this white line to follow any direction that we want. As we mentioned before, in order to measure IVC variability for fluid responsiveness, we should be distal to the hepatic vein takeoff. So I place the white line right here, distal to the hepatic vein takeoff. And what we can see here, this is the IVC diameter, and we can see that at the maximal dimensions, it is 1.4 centimeters, and with respiration, it collapses to 0.67 centimeters. So we can see here, respiratory variation, again, respiratory variation, and this collapse is greater than 50%. So this is suggestive of hypovolemia that will be fluid responsive. Here's an example of a normal IVC on M mode. Again, hepatic vein takeoff is here, the white line, immediately distal to the hepatic vein takeoff, and we see that the IVC is essentially static with respiration. There's minimal changes, definitely less than 50%. So this patient is not likely to increase their cardiac output with the fluid bolus. Now here is a clip demonstrating volume overload with inferior vena cava. This is just color Doppler demonstrating that this is a venous structure, and also it's looking for hepatic vein flow reversal that can be seen in volume overload. Now again, I'm going to play this clip, and just look, this is hepatic vein here, and this is the IVC diameter. It's big, and it is not collapsing or changing its diameter significantly with respiration. Now again, sometimes it can be tricky to appreciate this with just a small clip, and that's where the M mode can become useful. So we place M mode at that exact area distal to the takeoff of the hepatic vein, and we can see that the IVC is big and really does not change its diameter with respiratory changes. And signs of volume overload based on your IVC exam are IVCs that have greater than 2 centimeters of diameter and have no respiratory variation, such as this one. Okay, so now let's go over some abnormal ultrasounds. Now we can see here, this is the parasternal short axis. We can see the left ventricle in a nice circle, the right ventricle, the septum. We're at the level of the papillary muscles, which we said is the best level to make hemodynamic assessments. Now this is an example of grossly depressed LV function. Now pay attention to the LV diameter. I'm going to play the clip again. It really doesn't change that much in contrast to the normal left ventricular clip I showed earlier. Now here's another view, the parasternal long axis, demonstrating how this is depressed left ventricular function. We see the left ventricular cavity here, and really, there's not that much change. This is a patient with grossly abnormal LV function. Now this is another echocardiographic syndrome that intensivists should be very familiar with. This is acute cor pulmonale, or acute right ventricular dysfunction. Now, this is an apical 4-chamber view that shows the 4 chambers of the heart: right ventricle, left atrium, right atrium. Now, immediately, what should jump out is the right ventricle is significantly larger than the left ventricle here. And if you look at the apex, the right ventricle has completely overtaken the composition of the apex. So this patient has acute cor pulmonale. Now this is the same patient in the parasternal short axis view, and we really see the secondary signs of RV dysfunction or RV failure here. Remember, this is the left ventricle, this is the right ventricle. Under normal circumstances, the left ventricle should be much bigger than the right ventricle, and the left ventricle should really be a circle. As we can see here, the septum is bowing into the left ventricle and has flattened. This is a D-shaped ventricle that we see with right ventricular failure. Now in this image, we can see a subcostal long view with a pericardial effusion. Remember, in ultrasound, fluid is going to be dark or anechoic. And we can see here the 4 chambers of the heart: right ventricle, left atrium, right atrium. And the red arrows are pointing at the circumferential pericardial effusion. Now, our echo can really just tell us whether there's an effusion or not. Tamponade is going to be based on the clinical presentation, but there are echocardiographic findings of tamponade physiology. In the next clip, we'll see. So here, this patient has echocardiographic evidence of tamponade. First of all, this is a subcostal view. We see a large pericardial effusion that's circumferential. And the classic hallmarks of tamponade are going to be pressure overload causing the right-sided chambers to collapse. First, we'll see right atrial collapse with systole. Then we will see right ventricular collapse with diastole. And another secondary sign that can be helpful is a swinging heart sign, in which the heart is just moving back and forth within the large pericardial sac filled with fluid. This is essentially the echocardiographic correlation of electrical alternans, which we can see on the EKG. I'm going to play the clip again, and remember, this is a subcostal long, so the right ventricle is here, left ventricle, right atrium, and left atrium. Now pay attention to how the right ventricle free wall over here scallops in, indents, which is a sign of right ventricular collapse. And you can also appreciate the heart swinging back and forth within this large pericardial fluid. All right, so moving on to thoracic ultrasound. This is another important application of ultrasound that the intensivist should be very familiar with. The main things that we can appreciate with thoracic ultrasound are listed here. We can identify pleural effusion, hemothorax, pneumothorax, lung consolidation, as well as interstitial edema. So here are the basic views. Now, some practitioners actually endorse a 4-zone view on each side, making it 8 zones total, while some practitioners prefer this 3-zone approach on each side, making it 6 zones total. Now, essentially, you can do lung ultrasonography with any of the ultrasound probes, either the phased array or the curved linear or the linear probe that is used for vascular ultrasound. And we'll show you some examples. So this is lung ultrasound being done with the linear array probe. This is a high frequency probe that gives you good resolution and image quality for more superficial structures. This is the same probe that you do vascular studies and central line placements with. So first, it's important to understand what we're actually looking at. So typically, we're going to place the probe perpendicular to the ribs, because what we're trying to do is look at a space between the ribs and identify pleura. So here, this is one rib, this is another rib, and I know this is a rib because I see this hyperechoic line, then I see what is essentially the rib here, and then I see shadowing beyond. And remember, ultrasound can't go through bone. That's why we see this shadowing that goes down like this. So I know that this is rib, rib, and that the space between the rib is where I'm really looking at. And this bright line here is the pleural line, and this is the line that I'm trying to identify. So we can see here, rib, rib, shadow, shadow, and then this pleural line. And these striations that are hyperechoic that go from the rib down here are the intercostal muscles. Now this is another normal lung exam with now using the curvilinear probe. And again, we're looking in between ribs for the pleural line. And here, we can see rib, rib, rib shadow, and then pleural line. Now the curvilinear probe is going to give us much better depth. So we can see here, we can actually see all the way down to 11 centimeters, and we usually will set this probe to go even up to 18 centimeters. Now, what we see here are a common finding in lung ultrasound. These horizontal hyperechoic lines are called A lines. Now, A lines are essentially reverberation artifacts from the pleural line. So we can see it here, 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 and they'll continue to go down. And the most important thing to understand is that A lines are a sign of normal lung aeration. So A lines are not pathologic. They actually identify normal lung. So this is a normal lung with normal A lines. Now, one of the important things that we look at when we're doing lung ultrasound is whether or not there is lung sliding. Now, what lung sliding actually means is, you see this hyperechoic pleural line, is whether with respiration it moves back and forth. Now, it can be a little bit difficult to appreciate that, but pay attention. I'm going to play the clip again. And we can astoundingly see that this hyperechoic line goes back and forth with respiration. So the presence of lung sliding rules out pneumothorax at the location that you looked at. So that's very important. The presence of lung sliding rules out pneumothorax at the location you're looking at. So now let's look at an example of no lung sliding. So this is a patient that has a right-sided pneumothorax identified on lung ultrasound. So remember, lung sliding is the pleural line going back and forth. Now, it can be confusing because there was definitely some movement, but that wasn't pleural sliding. That was the patient's thoracic cage moving with respiration. So we can see that since the patient has a pneumothorax, they're probably using more of a respiratory effort, and we actually see the entire ribs, intercostal muscles, and everything moving back and forth, but not pleural sliding. What we're seeing is the structures up here going back and forth, but not actual pleural sliding. I'm going to play that clip again. So you can see, and if you just pay attention, the ribs and the muscles are moving significantly, but this pleural sliding is not occurring like it was before. Now again, this can sometimes be difficult to appreciate, so let's show that clip of normal lung sliding here so you can appreciate. So you see the pleural sliding just really going back and forth, back and forth, back and forth. Different. Play it again. Now again, this can be confusing for the novice. So actually, there's another way that can be a little bit more convincing and easier for the novice to appreciate. And that is putting M mode right through here. So this is what occurs when you have a pneumothorax. So this is the M mode right in between the rib spaces with the pleural line right here. And what you see is called the barcode sign. Now with a pneumothorax, you'll see striations that continue all the way to the pleural line and continue to go on and on and on. So over here, this is consistent with the pneumothorax because we see striations and linear hyperechoic lines that continue all the way to the end of the screen. This is different than over here on the left lung where there is no pneumothorax. And here we see this seashore sign. And this is called a seashore sign because these striations represent the ocean, and then this whole grainy area represents the sand. So this is normal. So if you see this, there is no pneumothorax. And this is essentially because what's happening over here is lung sliding is occurring beyond the pleura. So you get this hazy, sandy, grainy appearance because lung sliding is occurring. While over here, no lung sliding is occurring. So these straight lines that start all the way over here above the pleura continue on beyond the pleura because there's actually no lung sliding going on. So this is an easier way for novices to identify whether or not there's a pneumothorax. The next application that is really useful for the intensivist regarding thoracic ultrasound is evaluation of pleural effusion. So for dependent pleural effusions, the best place to look at is in the mid-axillary region on either the right or left side at the level of the diaphragm. So what we can see here is the liver on mid-axillary on the right side. This is towards the head, or cephalad. This is towards the feet, or caudad. And what we can see is this large pleural effusion encompassing above the liver. So the diaphragm is right here. This is the thorax. And normally, this should be filled with aerated lung, and we shouldn't see any of this dark anechoic fluid. Remember, on ultrasound, fluid appears dark. And this red arrow is pointing towards atelectatic lung. So this is compressive atelectasis of lung tissue with this large pleural effusion. So we can really appreciate on this clip. Here's liver. There is diaphragm that goes around the liver. And we see this large pleural effusion with this atelectatic lung that is kind of flopping back and forth within this pleural effusion. Now, the last thing we can do with lung ultrasound is identify whether or not there's a pattern consistent with interstitial edema. And what we're looking for is something called B lines. B lines are pathologic, very different from A lines. B lines are bright hyperechoic lines that originate at the pleura, so here's the pleural line, and extend all the way to the edge of the screen, typically beyond 18 centimeters. So we can see here, bright hyperechoic line extending all the way to the screen, bright hyperechoic line extending all the way down, bright hyperechoic line extending all the way down, bright hyperechoic line extending all the way down. And B lines are typically going to be associated with conditions of interstitial thickening, most commonly pulmonary edema. And having more than 3 between a rib space is pathologic. So here in this clip, we can see the multiple B lines originating from the pleural line, extending all the way down to the edge of the screen. And the important thing is B lines move with the pleural lines, and they efface any A lines if A lines were present. We can also identify lung consolidation with ultrasound. So remember, normal lung really should not be able to be visualized with ultrasound because it's filled with air, and air does not conduct ultrasounds. So this is, again, in the mid-axillary at the level of the diaphragm. Here we have liver. Here we can see the diaphragm, this hyperechoic line hugging the liver. And superior, or cephalad, this is towards the head, we see this dense consolidation. So this is all lung that is superior to the diaphragm that is consolidated. So typically we should not see this lung here because it's filled with air and ultrasound does not go through the air. These green arrows are pointing at air bronchograms. Now, when we see consolidation, we look for these signs, these air bronchograms, and we look for the lung having a solid organ appearance. This is called hepatization because it looks like the liver. You see this? This looks like a solid organ. This looks very similar to liver architecture. Now, this clip really demonstrates these hyperechoic dynamic air bronchograms consistent with the pneumonia. Okay, so moving on to vascular ultrasound. The intensivist really needs to be familiar with the use of vascular ultrasound for procedures such as central line, arterial line placement, and then for identifying venous thrombosis. Now, I showed you the study earlier that demonstrated an accuracy of above 90% for the intensivist for diagnosing deep vein thrombosis. Now, the ultrasound that we do for DVT exam at the bedside is not the same as a diagnostic ultrasound that radiology or vascular lab will do. It is simple compression and evaluation of the vein. So the things that we're going to do, a 2D compression exam. First, we'll identify the vein, and then we'll examine the vein to see if there's any echogenic material within the lumen consistent with thrombus, and then we'll compress the vein. If the vein fully compresses, then there's no DVT at that level. If the vein does not fully compress, that is concerning for having a DVT. And we'll perform this exam essentially at 5 different zones. The common femoral, most proximally, then at the level of where the saphenous vein branches off, and then at the level where the common femoral bifurcates, the deep femoral and superficial femoral vein. We'll then look at a zone with the proximal superficial femoral vein, and then we'll go on to look at the popliteal vein and when the popliteal vein trifurcates in that area. And we're simply examining the vessel and compressing. So here's an example of a normal ultrasound at the level of the common femoral vein where the saphenous vein takes off. So I'll play this clip again. Here's the common femoral vein, and here's the femoral artery, and this is the branch of the saphenous vein taken off from the common femoral vein. And we can see that the venous structures are easily compressible. The venous structures are dark anechoic without any echogenic material within them. So this is normal. No evidence of DVT at this level. Now I'll play this clip again. So you see the common femoral, you see the saphenous takeoff, and you see the full compression of the vein. Obviously the artery is not fully compressible since it's a highly pressurized vascular structure. Now contrast this with this over here, a positive DVT. Now immediately I can tell you here's the femoral artery, and then here is the common femoral vein, and within the common femoral vein you can see this echoic echogenic material, very different from here where it's dark anechoic and nothing in there. Now let's compress and see what happens. And we cannot fully compress, and you can see the clot just kind of moving around in that vein. So this is consistent with the DVT. Now, abdominal ultrasound is another application that the intensivist needs to be familiar with. And essentially, the main thing that they should be familiar with is the identification of free fluid in the abdomen. Some other utilities could be identifying obstructive nephropathy, such as hydronephrosis, and then depending on what type of intensive care unit you practice in, or whether or not you see patients very early in their course, you may want to be able to be familiar with imaging the abdominal aorta. But I think the real focus for the intensivist is to do an exam that will be able to identify whether or not there's free fluid in the abdomen. So the exam that really is the best for this is the FAST exam. The FAST exam is the focused assessment with sonography and trauma. So this is the exam that is done in all acute major trauma facilities that receive patients that have suffered a major trauma. Now, this is done during the primary survey of airway, breathing, circulation, disability, exposure, and then the FAST comes in. And what essentially the FAST does is it rapidly identifies whether or not there is intraperitoneal fluid or pericardial fluid, which in a hypotensive patient that has undergone a major trauma, this could indicate the patient going immediately to the OR solely based on the results of the FAST exam. Now, the overall sensitivity and specificity obviously is operator dependent, but the specificity is very high no matter what study you look at, above 90%. The sensitivity ranges, obviously, anywhere from 70 to 95%. So it's a very specific exam, and it can be a decently sensitive exam based on experience. The 4 views that we look at are the right upper quadrant, Morrison's pouch, left upper quadrant, the splenorenal recess, the suprapubic area, and then the subcostal long axis, looking for whether or not there's pericardial fluid. And it's a very quick exam, and we're just looking for dark, black, anechoic fluid where there shouldn't be. So this is Morrison's pouch, or the right upper quadrant, and the structures that we can see here: liver, kidney, diaphragm. And this is a normal view of Morrison's pouch. The kidney should be right up next to the liver. Here's some fascia, but there really shouldn't be anything separating the kidney and the liver. Now, fluid tends to accumulate around the liver and then fills into this area called Morrison's pouch. So a positive FAST would accumulate between here, the kidney and the liver, and if it's really large, can track around the liver. And here's the diaphragm. Now again, this is cephalad, this is caudad. So this is also the same view that we looked for when we were assessing for pleural effusion. So pleural effusion would be found here if the patient did have one. So here, this is a positive FAST in the right upper quadrant. So again, structures: diaphragm, liver, kidney, and then here we see dark black fluid accumulating all around the liver and into that Morrison's pouch. So this is a positive FAST. So if this patient was an acute blunt trauma patient that was hypotensive, this patient would get large bore access, massive transfusion protocol would be started, and the patient would go directly to the operating room. This is another image of the suprapubic area. Here we see the bladder cut in the sagittal view or longitudinal view, and we see the bladder, which is obviously a fluid-filled structure, which is supposed to be fluid-filled, and we see fluid outside the bladder, this dark anechoic. So this is a positive FAST. So that really is going to be the main thing that all intensives should be familiar with in terms of abdominal ultrasound. Lastly, the procedures. So central line, arterial line, thoracentesis, paracentesis, lumbar puncture, ultrasonography can make all of these procedures safer and actually easier to perform. Now, I think most places it is standard of care for an internal jugular central line to be placed under ultrasound guidance. Now, this is the latest Cochrane review, and it really reaffirms this. There's lower failure rate with ultrasound usage, higher first attempt success rate. It takes less time to perform the procedure. You have decreased rates of arterial puncture and decreased rates of hematoma. Even with radial artery catheterization or radial arterial lines, ultrasound improves almost all of the same things. There's decreased first attempt failure, decreased mean attempts to success, decreased mean time to success, and decreases of hematoma complications. Now, this is based off another meta-analysis that was recently published. So even arterial lines, it seems that ultrasound is going to be a better approach, at least for the patient. Now, this is a nice sequence of ultrasound clips of an arterial line placement. Here we can see the radial artery. Here is the needle of the catheter. And as it approaches the radial artery, now you can see the needle firmly within the arterial lumen. And then the catheter is threaded in. And here we see the radial artery with the arterial catheter, a nice little cross-section of it in place. Ultrasound improves thoracentesis as well. It reduces complication rates and also reduces the risk of pneumothorax. So really, ultrasound is going to make most of the procedures that you do in the intensive care unit safer and easier to perform. So it's paramount that the intensivist is at least familiar with how to do these with ultrasound, because oftentimes, even if you don't do the procedure first with an ultrasound, failed procedures without an ultrasound are usually able to be done with ultrasound guidance. Or ultrasound guidance explains to you why the procedure actually is not going to be successful. So I will oftentimes have an ultrasound at the bedside of the patient, even if I'm not going to use it for the procedure I'm going to do. All right, we went through a lot of information, so let's put it all together. So this is the algorithm that I suggest you use for the patient that undifferentiated shock. There are multiple other algorithms that have been published or written about, and they all essentially do the same thing, maybe in a slightly different order, but essentially it's a very similar protocol to other established protocols that have been written about. So you have the patient in undifferentiated shock. Now, the first thing you're going to do when you're evaluating this patient is the cardiac echo. And you're going to get immediate information about the patient. If there's a big pericardial effusion, tamponade, you're done. You know that the treatment needs to be emergent drainage. If you've identified a depressed LV function, then you move on and you start inotropes and consider myocardial ischemia as the cause of the patient's shock and start to work that up as well. If you see a large dilated RV, consider pulmonary embolism as a source of shock or other causes of acute right ventricular failure, like worsening pulmonary hypertension, right ventricular myocardial infarction, et cetera, et cetera. Now, if you've done your cardiac echo and you see that there's a normal LV function or a hyperdynamic LV, then move on to your IVC view. And if you don't see any IVC variation and the patient's hypotensive in shock with a normal LV function or hyperdynamic LV function, then start vasopressors, because this patient likely is in distributive shock and needs vasomotor tone. Now, if you do the IVC view and there is significant variation, the next thing to do is check lung ultrasound and see if there are multiple B lines. If there are no B lines, then this patient is hypovolemic and administer volume as needed and repeat your ultrasound until the IVC is no longer variable and or B lines are present. Now, if the patient does have IVC variation with inspiration, but there are multiple B lines, then that's indicating that the patient has pulmonary edema and is still likely volume responsive. My recommendation in that scenario is cautiously give small boluses volume, consider early vasopressors. And then lastly, obtain additional views that you may need depending on the clinical scenario. For example, it's a trauma patient, then you're definitely going to do your FAST. If it's an undifferentiated patient with abdominal pain, you may want to look at the aorta. Why is this patient hypovolemic? Is it because they have an aortic aneurysm and they've ruptured? And then also don't forget, when you do your lung ultrasound, you're going to look for sliding and see if there's pneumothorax, tension pneumothorax. So in summary, ultrasound can be very useful in the intensive care unit. The applications that the intensivist should be familiar with are basic cardiac, thoracic, abdominal, vascular, and procedural ultrasound. Ultrasound can help answer the critical questions in the acutely crashing patient. Why is my patient in shock? Is my patient likely to be fluid responsive? Why is my patient respiratory status deteriorating? And again, ultrasound has been shown to make common ICU procedures easier and safer. All right, so let's move on to a post-lecture test. So here's the question. We're going to go through the scenario 3 different times. It's the same scenario, but the bedside ultrasound changes in each scenario. So this is a 40-year-old female with a history of lupus and recent flu-like illness admitted to the ICU for fever, hypoxia, and hypotension. The portable chest X-ray done in the ED is read as a right-sided effusion. The ED physician administered 4 liters of normal saline, broad-spectrum antibiotics, placed a right-sided subclavian central line, and started the patient on a moderate dose of norepinephrine. The patient arrives in the ICU and is still hypotensive. The vital signs are heart rate 122, blood pressure 81/46, temp of 100.6, respiratory rate 28, satting 93% on 6 liters of nasal cannula. The nurse looks at you and says, "What do you want to do about this low blood pressure?" So you very astutely grab your ultrasound and go into the patient's room and start to scan. So this is the apical 4-chamber view that you see. This is the inferior vena cava view that you obtain. You can see that, and there's no change in respiration. And lastly, you do lung ultrasound, and this is the lung ultrasound that you see. So what should you do next? Should you A, administer 1 liter of normal saline bolus, B, administer thrombolytics, C, start vasopressin at 0.04 units per minute, D, administer 100 milligrams of furosemide, or E, needle decompression followed by chest tube placement? The answer in this scenario is C. Now let's just go back and look at these images. So here we have the apical 4-chamber view with good LV function and no RV enlargement. So this is a normal apical 4-chamber view. So the patient has good LV function. But look at the inferior vena cava view. The inferior vena cava here is huge. These are 1 centimeter markings, so it's at least bigger than 2 centimeters. And I mentioned that it does not change with variation, which tells me that this patient has been significantly volume resuscitated. And furthermore, we do a lung ultrasound and we see multiple B lines. So remember, these bright hyperechoic lines that originate from the pleura and go all the way to the edge of the screen. This indicates that the patient is already having pulmonary edema. So we have a patient that was hypotensive, febrile, and received 4 liters of fluid and is on norepinephrine that is still hypotensive with signs of pulmonary edema and signs of being volume repleted. The patient likely is in septic shock and needs vasopressin as a second-line agent. Okay, so same scenario, but this is the ultrasound that you see. Play it again. So you see this ultrasound and you're concerned, and you go on and do this next ultrasound as well. This is a still image from that ultrasound. There is no compressibility of the vascular structure that you've identified here. So what should you do next? Administer 1 liter of normal saline, administer thrombolytics, start vasopressin, administer 100 milligrams of Lasix, needle decompression followed by chest tube placement. The answer is B, administer thrombolytics. Let's go back and look at those images. This patient is having an acute pulmonary embolism with acute RV strain. So if we look at the echo that we did here, this is a 4-chamber apical view, and we see the RV is very big. It's almost twice the size of the LV. It takes up most of the apex. The LV is moving very well, while the RV is not moving at all. So this is consistent with acute cor pulmonale. But again, this could be caused by multiple etiologies. But the next ultrasound that we did demonstrates a huge thrombus within the femoral vein. So this is the femoral artery, this is the femoral vein. You see this echogenic structure here. This is thrombus. And then I had mentioned that this was not compressible. So this patient has signs of acute RV dysfunction, is hypotensive with a large femoral DVT. This patient has a massive pulmonary embolism, and the treatment for that should be intravenous thrombolytics, or if you have some sort of interventional pulmonary embolism team at the institution you work at, you can have them activated. Good. So now the last scenario. It's the same exact scenario. It's the 40-year-old female, recently admitted with hypotension fever, and got 4 liters of saline, got a right-sided subclavian central line, and is on a moderate dose of pressors. The patient has the same vital signs, tachycardic, hypotensive. The nurse asks you, what should we do? So you do your apical 4-chamber cardiac view. Then you go on and do a long ultrasound. I'll play that again. And you do M mode. What should you do for this patient? A, administer 1 liter of normal saline. B, administer thrombolytics. C, start vasopressin. D, administer furosemide. Or E, needle decompression followed by chest tube placement. The answer is E. So this is a patient that has signs of a pneumothorax on the right side of the chest. So let's go look at those images again. So here we have the apical 4-chamber view. Again, this is just demonstrating normal heart function. The RV is smaller than the LV, and the LV has good squeeze. So this is just to illustrate the patient has a normal heart function. Now, on the right side, pay close attention to the pleura. There really isn't that back and forth lung sliding that we want to see to identify if there's lung sliding. Now again, this can be confusing for novices, so we go on and we put M mode. Now here, we clearly see the barcode sign. You can see these striations that begin above the pleural line, continue, 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 continue. So the hallmark of a pneumothorax is the striations above the pleura continue beyond the pleura. So here's the pleural line, these linear striations that are above continue and look exactly the same above the pleura, below the pleura. This is the barcode sign, the sign that there is no lung sliding and the patient has pneumothorax.